which is a psychosocial rehabilitation program for people who have been hospitalized in mental institutions. Did I do that right, Julie?
Yeah, I'll cover
the
it.
show. You go for that? That's kind of an impressive bite to take out of the idea of mental health. That is, that you are going to undertake the responsibility of returning someone who's been isolated from normal functioning for a while and get them back into normal functioning, or
Into normal society.
normal society. Okay. How does your program work first?
We are basically a program designed to work with people who have had chronic mental illness, which means multiple hospitalizations. We talk about close to 5 hospitalizations as our average in intake.
Someone with a history of manic depressive.
Typically manic depression or depression, the affective disorders as it's called, or the schizophrenic processes. Between those two diagnoses, we probably cover 80, 85, 90% of our population.
Schizophrenia is an umbrella term anyway.
Exactly.
That covers a whole multitude of things. Yeah.
It really is quite meaningless from a technical point of view, but it's usually associated with the people who have an inability to function realistically in the community and who have had multiple incidences of a need for professional intervention, care, hospitalization. So in many ways, it's viewed as the more serious forms of mental illness are usually diagnosed as schizophrenia.
I can hear people watching this show saying, oh, what does this have to do with me? I mean, I'm not manic depressive and I'm not schizophrenic, and certainly those are terrible, horrible diseases and they only happen rarely. I know that's not true. You want to tell something about that?
At any given day, more than 50% of the occupied beds in hospitals in general are occupied by people with psychiatric illnesses of one sort or another. And the largest majority of those are from schizophrenics. 1 out of 10 people will be involved to the point where they should have therapy in their lives, and about 30 to 40% of the families in the country will have a close family member having been diagnosed as 30 to 40% of the families will have a close family member within a cousin range that have been diagnosed as schizophrenic or manic depressive, which basically means we're all touched by it.
Right, so a good 1/3 or more of all the people who are watching the show will have some intimate connection with it. They
Definitely.
might even have a job associate or a friend at another level, so that the chances increase. Manic depression is something that can come with age. Is that not so?
To a point. Usually, but if you have not had an episode that would require clinical intervention by 40 or 45, you're pretty safe. Similarly with schizophrenia, unless it is a menopausal reaction for some women.
I think I know of one who had that. In other words, a woman in her 70s who had a manic depressive reaction and had no previous histories.
As a rule, we have found that people do have a previous history, maybe barely subclinical though.
Unrecognized.
Unrecognized, but when we find out what they've done in their lives, we get people who have had problem adjusting to marital relationships because of mood swings. They've been very moody.
Right.
Or we have people who at various times in their life have lost a job because they couldn't get along with an employer. Or people who needed extra help. They're the one in the family. We will put up with him, we love him, but geez, he's hard to live with.
Right.
And it's never gotten to the point where they really have to have clinical intervention, although it might have been better in some cases if they did.
I am a person who is manic depressive. I am now controlled by lithium, basically. When my family placed me in the institution, it was with a great deal of anguish. I was in my manic phase and went out and bought everything in sight.
On other people's charge cards.
On other people's charge cards. I drove recklessly. I had such elated highs that normal safety precautions, I felt I could fly out the window. But when my family put me in the mental hospital, they recognized that they could not take care of me at that point. There was a great deal of guilt and relief on their part when I went in. And now I am coming out. There is a great deal of trepidation on their part as to how I'm going to behave, because they're not quite sure. They've had many episodes before. But I'm coming out to you.
Okay.
Now, what's different about my coming out to you as opposed to my family picking me up at the hospital and returning home? What will you do that's different?
I think the first thing that we would do, and a major area of emphasis in our program, has to do with the fact that a substantial percentage of the recurrence of mental illness, be it manic depressive, schizophrenia, or many other forms, has to do with medication problems. You come out, you feel better about yourself. You haven't had problems for 3, 4, 5 months. Well, I don't really need this stuff anymore, so I'm going to cut down. A week later, you're not feeling so good, so I'm going to take 4 extra pills. And you're in trouble again. One of the things we do, we have a very strong orientation towards medication education. All of our members know what the lithium does to them, both physiologically and emotionally. We work very diligently to help them accept that there is a reasonably good chance they're going to be on psychotropic drugs, lithium in this case, or whatever other one, for the rest of their lives.
Like a diabetic needs insulin.
Like a diabetic needs insulin, which is one of my favorite examples.
I didn't know that.
But that's reality, because the newest studies have shown that manic depressive particularly, as well as other forms, but there's been a lot of work with the manic depressive disorders, the affective disorders, is very, very much tied to brain chemistry.
Yes.
And that lithium corrects the balance of chemicals in the brain to avoid the future episodes.
Do you think that it's necessary here to say that both the schizophrenias and the manic depressives, for a non-professional audience, that this is very much involved with brain chemistry very often and is not something that the person has control of? It is not.
Yes.
I mean, sometimes we assume a more sophisticated audience than medically really possible, and that those are things that the person has no control over. They happen to them.
That is a very, very important concept for the family.
Yes.
To help them accept that it's not because of bad parenting, it's not because of a stubborn child or a willful child, or the child hates me or out to get me,
Right.
or anything like that. It's simply because there is a chemical imbalance that interferes with the transmission of thought process and mood process within the brain. The person is no more at fault than the diabetic is at fault, than the heart patient who must take his digitalis or his various other heart medications. This is not a willful disorder.
I think since most of your patients do tend to be manic depressive or schizophrenic, that most people assume that there is a willful or some sort of process whereby the person has put themselves in this position. If they had only done what I told you or done differently, then they wouldn't be in this trouble, and that the person with these kinds of mental problems is a person who has a broken something, like you have a broken leg or a broken back, and you need not only the recuperative time, but you need the proper kind of care in order to survive.
There's one modification on that, though.
Okay.
The same as with a broken back or broken leg. There are exercises needed during healing. You have to restrict the motion at times. The person has to be careful not to do this, that, or the other thing. One of the things we also work with our people is to try to teach them what types of experiences tend to create more anxiety with them and experiences that they should avoid. that are likely to trigger off the physiological response. Again, parallel to diabetes, if the diabetic goes out and goes on a candy binge, all the insulin in the world won't help. Or if they don't take their insulin and then follow it up a half hour later with appropriate food, the insulin is not going to be as effective.
So again, here I am, and I am learning to handle my disease, my manic depressive disease, and I tell you that when I go shopping that I really feel this elation and this uncontrollable, and that's a big temptation for me. In a group setting, would you role play with me how to control myself when I went into the store, or how to pace myself in terms of?
We would work on a different level. Not that that wouldn't be done at times, but that's not our primary approach. Our primary approach involves a very comprehensive program. All members coming into our agency will be given will be involved with one of our vocational programs. We have in-building vocational work crews. This is to evaluate the individual's ability to deal in vocational settings, not necessarily on a skill level, but to deal with their ability to work with coworkers, to work with supervisors, to understand the process of completion of a job, to test their efficiency in completing a job, to test their work tolerance, to evaluate what parts of a job they feel most comfortable with.
Would this be an office? Would this be skilled as well as semi-skilled?
No, we work
kind of work?
primarily with unskilled at that level. Deliberately, part of it is the reality of the jobs that we have available as part of our program. But the other part of it is we want to put the person in a position where there's a minimal emotional challenge. The more you are using your potential, the more stress you are under. Yeah. And we're still dealing with somebody that may have been hospitalized 4, 5, 6 times, coming out of the hospital. That doesn't mean they're healthy. All that means is that the immediate symptoms have been reduced. They're not hallucinating, or hallucinating less, or hallucinating less.
Let me back up a minute, because you said something that I think bears repetition, and that is when you are discharged from a hospital, again, as if having surgery in a general hospital, and it's time to go home, you are not well.
You are not cured.
You are not cured. You are better. I think that's
Exactly.
what I mean to say. And with the mental hospital, whatever things are not yet better are not always clear. And people expect, and I know this from experience,
Sure.
people expect to come out of a mental hospital all better, whereas they don't come out of a general hospital all better from their surgery. I mean, they have to go home and they have to recuperate and do all these other things. But people have a different expectation about when someone is released.
Mm-hmm. Very true. And in many ways, release from a mental institution usually means an abatement of symptoms. It does not necessarily have a thing to do with the cause of the symptoms. So the person has been given the appropriate medication, the symptoms are reduced, they're no longer a danger to themselves or others, which is the only legal definition to keep a person in the hospital, and therefore they're released. They still may have failed on many jobs. They still may have an inability to socialize effectively. They still may never have had a successful experience in independent living. They still may not understand the function of their medication and why to keep on it. And I can keep going with this list. All of these things are things that we work with. So the person is involved, as I said, in a vocational program. When they get to the point of using our in-house vocational crews effectively, we start them on community-based jobs. Their first step will be as part of a group, going to an employer's environment with one of our staff. Maybe working on, again, simple jobs, deliberately picked that way. Maybe working for 2 or 3 hours once a week or twice a week. Because that is a gradual introduction into the anxieties of the world of work.
Julie, how does the family get involved in this, or don't they?
All new members, and we call our people members not as a cute name to avoid the designation of patient or client, but as you see with a vocational program, similarly with our other programs, when a person joins thresholds, they take on a responsibility to our organization. Part of the responsibility is to help themselves in their own rehabilitation.
What is some of the other part?
The other part is we expect our members to be able to perform in the organization. My switchboard is answered by one of my members. My office is cleaned by one of my members. My non-confidential typing is done by the members. They take on a commitment to the organization, and through the performance of this commitment, they help themselves. Well, isn't that the way when you join any organization?
Absolutely.
You get from it and you give to it. That's what we do with our professional organizations.
Right.
Therefore, members is a very apt term in our setting.
Members of a certain community that
Exactly.
helps each other.
Exactly.
Okay.
I lost the original question.
Oh, well, how is the family involved?
Okay. All new member families are invited to an orientation held approximately once every 5 to 6 weeks, where we describe thresholds, we talk about it, we tell what we do. They have a chance to ask questions, to understand our goals, to try to see what we're doing with their individual children. Now remember, their individual children can be a 40, 45-year-old adult, but it's still their children. As a second step in that, those who choose, and they're encouraged to, can join an ongoing family group dealing with group problems of the parent that one has with the parents of the mentally ill, where the stigma affects the family, where the relationship with the youngster, the adult, the person, is likely to have been stressful, because mental illness shows itself in behaviors in relationship to other human beings that are stressful. So they are stressed out.
Yeah.
And we dealing with their own stress. We will, where indicated, particularly with our younger population, we do have a young adult population between
Your
16.
age?
Our age is 16 through 50, but we have a subgroup of 16 through 21, where because of their youth, there are many differences in their handling because they're really adolescents, even though they still may be 21. If any of them are listening, they don't like that. But and in that issue, we make very strong efforts to get the family involved in counseling situations with the youngster. What we aim for in the family counseling in general, either in the parents group, the parents orientation, the family counseling with adolescents, or the family counseling with our adult members where that's indicated, is to deal with the relationships in the family that interfere with a person's successful adjustment in the community. Now, again, remember, we're working with adults primarily, and the same as I did not go through a family counseling session to normally separate from my family, it is not always indicated. Because many of the people are better off trying to mainstream into the normal process of separation from the family than using the family counseling process. But that depends on individual needs.
That's an individual assessment.
Yes.
If I was 40, 45, 50, even your maximum, would it be likely that as the person who comes to see you that I have been in a series of repeated hospitalizations, that I have not socialized sexually, that I've had few intimate relationships of any significant nature, that I may have aging parents who have kind of tended or run after me for most of my life, and that I do not really have effective social skills to lead a normal life and never will?
You will have better skills with the scenario you've written. I'm not sure if you would ever have what the average person would consider effective skills. But when you work with a younger person, there is a more likelihood of developing more effective skills, although interpersonal relationships, socialization, seem to be one of the more anxiety-producing areas for people in general,
Right.
and very specifically a usual area of deficit. I would say that one of the bellwethers of an increase of problems are a decrement in the ability to relate effectively to others, and we see that all the time. Therefore, we do have a well-developed social program also.
I was going to say, do you encourage socialization then among the members?
They start out socializing in the building, and we have a number of groups at various levels. For example, we have a number of groups dealing with conversational skills. Small
Hi,
talk.
how are you?
Small talk.
Right.
The key
see the
to
Olympics.
exactly that is frightening to many of our people. And we deal with, what do you do the first time you meet somebody in a party? How do you pass 3 or 4 minutes where
Holding a drink, eating an hors d'oeuvre, and talking all at
not
the
holding
same
a drink?
Oh, okay.
Psychiatric medication, not
Ginger
holding
ale.
a drink, holding
Ginger ale.
ginger ale,
I mentioned a liquid,
a liquid,
a glass.
a glass, eating an hors d'oeuvre, and talking about the Olympics, the weather, the latest headline in today's paper, or what have you. Particularly if you don't have a successful work experience, which is a major concept of conversation. How do you deal with those issues? What do you do? And we actually have conversational skills groups. Those are usually the simpler, more introductory groups.
Is this a residential treatment program?
We have a number of residences for those people who need them, and that's a good percentage of our population. In 1977, the Senate Select Committee, I think Humphrey was the chairman at that point, investigating the major problems of adjustment of mental illness in the community, said that the most severe problem, the greatest unmet need, is adequate housing for people with psychiatric history. Thresholds has become a leader in the nation on alternative techniques of housing, from well-supervised, monitored, small group homes through shared apartments in the community with about 4 or 5 sequential steps in the middle for people to avoid the need to go to the large shelter care facility where you have 400, 500, 600 people under one roof, to avoid the, what I call welfare rooms, which are in welfare hotels. That is nothing but a roach-infested closet with a string across the corner to hang a few clothes in. To avoid the need to be part of a family constellation where it is socially more acceptable for an adult to be living independently from the family if they can.
So in that sense, you try for normative functioning, age appropriate to where the person is in their life cycle.
Definitely.
But that doesn't mean that if someone had a 16 or 17-year-old schizophrenic who went through your program, that person might not eventually return normally to the family for whatever period of time they would be there, 2 years, 3 years, 4 years.
Very possibly.
They went to school. I mean,
many of our young adults live with the families because that is the appropriate setting for them. Many of them will have lived with the families as part of their move towards independence, will have moved into our residential program at a point in the future, maybe not return to the family. That would depend, although I think most of us, once having moved out of our familial home and lived independently, college, first jobs, working out of town, etc., tend not to return to the family homes. But if we really have a personal crisis where we lose the job and we can't afford the apartment, we can go home. I think our members would tend to follow that pattern in general.
could you, kind of quickly now since we're coming near to the end, if I was a family member looking at my person who just came out of the mental hospital and is now in your program, what are some of the 5 things I should do and the 5 things I shouldn't do? Could you, or don't be limited by my 5.
I understand the numbers are illustrative. I think one of the things that you said earlier is something that our members, the families must remember. This is not a naughty person trying to do something to harm you. And on the other end of the same scale, you must remember that you have a right to your own life, that you cannot devote your life to caring for a person. You are not helping yourself, and you are not helping them to create that kind of dependency for yourself or for them.
So self-sacrifice is really a worthless one in a sense, because now more than one life is diminished.
That's right. In fact, when we work with the parents, part of the message we give them is you have a right to your own life. And by exercising that right, you are saying to your child that they also have a right for their own life.
Yes.
They go hand in
They
hand.
model the message, yes.
Exactly, and that message goes hand in hand. So I would think that the two things, that and the third thing would be accepting and encouraging appropriate use of medication.
You mean the family accepting that the person is taking the medication?
That's right. Many families say, as long as you're on those pills, you're never truly well. Not an uncommon message. Or on the other hand, if the person has a bad day, as you and I can have, take an extra pill.
Right.
It's not a panacea. It's not going to cure bad days. Even on medication, you have normal moods.
Right.
But it is not something that is a stigma. And if the families learn to accept this, as we said before, as they would insulin, then it's much easier for the person to maintain their own medication regime appropriately.
Since we are near the end now, how would someone contact Threshold?
All they have to do is call 281-3800, ask for intake. We'll take it from there.
Who is eligible?
People with a psychiatric hospitalization history, no matter how many, I mean, we have people with 20, between 16 and 50 years of age. And I think the hardest thing for anyone to evaluate, but we'll do that, is people who are interested in changing their own lives.
Okay. Thank you very much, Julie Nessel. Julie is the Assistant Director of Thresholds, a rehabilitation organization for people who have psychiatric histories. This is Audrey Gordon for Sunrise, Sunset, the Jewish Family in Transition. Thank you much for being with us and sharing with us all of, I think, that things that have been of considerable interest to people who have problems in their family regarding mental illness. I hope that you can come back soon another time.
I'd like to.
Okay, thank you very much. Can we just wrap?